Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
If you aren't familiar with us, we'll go to our website, cpp.org, and I put the picture of the sisters down there in the corner to remind me to mention that we were founded by a group of Benedictine sisters back in 1985, and that's part of the reason that sometimes we feel it's appropriate to say some things you have to do just because they're the right thing to do. Next slide. So this was one of our attempts that we took. This is before the new coverage started rolling out in 2014. We looked at the estimated uninsured in Texas and said, what buckets do they fall into under the Affordable Care Act? And so we had a good chunk, almost 37% of our uninsured who, at least income-wise, appeared to qualify for subsidies in the marketplace. Some of them just premium subsidies, and some of them subsidies both for their premiums and their out-of-pocket costs. Then we have a chunk of children who are uninsured and not enrolled in Medicaid or CHIP, even though, according to everything we knew about them, they were already eligible for the program. Then we did have another group of folks that Senator Schwertner referred to who had incomes above 4 times the poverty level, and therefore they weren't going to get any kind of sliding scale help with subsidies, but they could buy coverage in the marketplace. So that was about 10% of our uninsured. And then we had about a 15% share of our uninsured population who are uninsured U.S. citizen adults. And those are the folks that fall into our coverage gap because they don't qualify for subsidies in the marketplace. They are in the concept of the Affordable Care Act. They were intended to get Medicaid, but we haven't provided them with that option, so they're left out. Then we have about 27% of our uninsured, it is a significant amount, who are not U.S. citizens. Probably about a third of those are folks who are lawfully present. Those are not all undocumented. And the best estimates we have is that about a third of those are lawfully present, and the other 2/3 undocumented. So that's sort of the picture we were looking at. It's not like any one piece of the Affordable Care Act was supposed to somehow pick up all of our 6 million uninsured. So next slide. So where are we on the marketplace? This is the part that it has rolled out in Texas. So the new marketplace, which first enrolled people for coverage in 2014, after our second year of open enrollment, we have 1.2 million Texans who enrolled and selected a plan. That's up from around 734,000 in the first year of 2014. The best estimate we have is that that's about 39% of the potentially eligible folks for marketplace coverage, which is estimated to be, as you can see there, around 3 million. The average nationally is 42%, so we're not horribly below average, but we are below average. And just to show, I would say, a state that we would aspire to be like, in Florida, they've enrolled 64% of their potential eligibles, and they have 1.5 million enrolled right now, even with a significantly lower population than we have. In Texas, from these latest statistics, 57% were newly enrolled people, 43% were renewals from the first year of open enrollment. 85% of them got financial assistance. The average premium across that whole group was $328 without a subsidy. It was reduced to an average of $89 after the credit, so the average subsidy is almost a 73% subsidy when you look across the folks getting help. 43% of Texans who are enrolled are paying less than $50 a month. 68% is paying less than $100 a month in the marketplace. 29% of those are between 18 and 34. That's better than the national average. And one of the things that's frequently misstated, I would say, sometimes in hyperbole, is that actually premiums increased only in Texas, only about 5% on average from 2014 to 2015. And for most of the people who were getting subsidies, their credits eliminated the impact of that increase. So the subsidized consumers in the marketplace were really buffered from that increase. Next slide. We have obviously had an uninsured rate decline in Texas. Evan Smith talked about the report that came out from the Baker Institute at Rice and supported by Episcopal Health Foundation. It showed an 8 percentage point drop, which is about a 1/3 drop in uninsured. Another piece that we have that is not Texas specific, it's national, are the Gallup statistics, and interestingly, they show much higher percentage reductions in uninsured and African American and Hispanic Americans percentage, but that the actual number, even though the decline in the uninsured rate for white Americans was only 5%, it was 6.6 million adults who gained coverage in that ethnic group, so that you actually have sort of about equal numbers of whites, and the combined number for African American and Latino nationally have gained insurance. So the rates aren't nearly as bad for white Americans, but since they are still a majority, we've had a substantial, the white gain in coverage has actually been equal to that of black and Hispanic. And just a reminder that our census asks questions about the previous year typically when they're doing numbers. So we won't have any numbers about that first year of coverage, 2014, until next fall for the first time. So that's why we're looking at things like special studies that Rice has done and a Gallup survey, for example. Next slide. So one of the things as we start into talking about, who's insured and who's not insured and who doesn't have an option still in Texas under the coverage gap, this is who we cover in Medicaid today. It's mostly children. We also have a much smaller but significant group of children in the Children's Health Insurance Program. So between Medicaid and CHIP, about 3.3 million children are covered, and most Texans don't realize that Medicaid is mostly a program for children, that there are hardly any parents of these kids. So we got 3 million kids covered on Medicaid and only about 150,000 of their parents. Maternity is obviously also a huge issue. I've already blown through a lot of my time, so let's keep going. I want to remind people that nearly half of Texas children were enrolled in Medicaid as of last spring. So this is when we talk about what has happened to Medicaid between 1989 and the present, as came up in the earlier, that's what happened. We started covering children. We also started covering pregnant women. We pay for 55% of the births in Texas or more, and between Medicaid and CHIP, nearly half the kids in the state are covered, and that's the difference between now and before 1990. Next slide. So the coverage gap situation that we find ourselves in is kind of this crazy situation. The bar on the left is what is happening in New Mexico and Arkansas, our neighbors. So if you're below 138% of poverty, then you can get Medicaid. This is assuming you're lawfully present in the United States. Undocumented people are not covered in Medicaid anywhere in the country. Texas is not an exception to that. And if you're above that, you can qualify for those subsidies, which, as we just talked about, are quite generous, and most people in the marketplace do qualify for some kind of subsidy. But because Congress was expecting everyone in this income group to get Medicaid, they decided, okay, we're not going to make anybody below poverty even eligible for subsidies. We're just writing that into law because this is not an option. And basically, once the Supreme Court came in and made that an option, it left us in the situation where our folks who are below the poverty line don't have subsidies in the marketplace and they don't have Medicaid. That little green slice over there is that little bitty group of parents that we do cover in Medicaid in Texas I talked about. Again, only about 150,000 parents, 3 million kids in the program. Most of their parents do not qualify for Medicaid. So that's the coverage gap group that we're talking about. The good news is if you're at 105% of poverty, you probably can go, and you're going to pay more out of pocket perhaps than you might have if Medicaid was available in your state, but you've at least got some subsidized coverage available. But if you're at 95% of poverty, nothing. So let's see what the next slide is. That's just basically what I just walked you through. So we crazily have the situation in Texas, and I promise you a lot of our elected officials over there at the Capitol still do not understand this, literally, that the family making $23,500, the parents get no financial help. They would have to pay full price of, say, $440 a month. That's a real premium from 2015 to get the two parents covered. But their next-door neighbors who make $1,000 a year more, they're above the poverty line, and they can get a subsidy, and they can pay $43 a month for the coverage for the parents. So this is the real situation that we find ourselves in Texas. Next slide. This is just a reminder. No, I'm sorry. This is just a reminder that most of the states that we are now, I believe, at the point where we have 29 states plus D.C. That have moved ahead, and 5 of those states have moved ahead with 1115 waivers that make substantial departures from existing Medicaid, and we'll talk a little bit more about that. There's a huge amount of information, much of it reflected by some of the sponsors of this event about the cost benefits Some of the most interesting recent developments are that the states of Arkansas and Kentucky have both reported that their savings from having already implemented Medicaid expansion, their savings exceed their GR costs. So this is actually saving them money in their state budget. 4 of the largest for-profit hospital chains in the country were studied by PricewaterhouseCoopers last year, and just looking at the first 6 to 8 months of their Medicaid expansion, they found dramatic reductions in uncompensated care and significant increases in patient revenues in those hospitals in the states that had done Medicaid expansion, but only very, very small decreases in uncompensated care in states like Texas that have not done Medicaid expansion. We're starting to get concerned about the revenue impact on our hospitals. We've led the nation in Texas in hospital closures. Since 2010, a quarter of hospital closures have been here in Texas. Mostly they're rural. You'll probably hear more about that soon. We're only 9% of the U.S. population, but accounting for a quarter of the hospital closures, something we should be concerned about. As Evan mentioned, there is a tie to the renewal of our 1115 waiver. I would have to push back on him a little that the federal statement was not that if we don't do Medicaid expansion, they'll take our waiver away, but they did say we don't think we're going to reimburse states for uncompensated care costs to this population when you have chosen not to take the federal funds available for this population. So there's really not a threat that the whole waiver is going to go away, but there's certainly a threat that it could be a smaller amount of money if we don't get to any kind of coverage solution. I think it's really too early to know what exactly that's going to look like. Also want to mention that we've got job creation estimates from folks like Ray Perryman and our former Deputy Controller Billy Hamilton that range from 200 to 300,000 jobs by the time you get into the 3rd and 4th year of implementation of either a traditional Medicaid expansion or an alternative waiver, as a number of Republican states have done. So we're now at a point where the Texas Association of Business and 24 chambers of commerce, and probably a growing number, we're adding more chambers all the time, have endorsed finding a coverage solution for Texas, and lots of other elected officials. So next slide. Red state alternative. So I'm probably going to wrap up pretty quickly with this, but the important thing to understand is everything, the kinds of descriptors that you hear conservative members talking about wanting to see in Medicaid are things that are clearly being approved in the states with 1115 waivers. We've got co-payments, we've got premiums, we've got wellness incentives, we've got health savings account type things. So anything short of saying no accountability and a block grant. If no standards and a block grant is the only thing you'll accept, then we can't get there. This is true. But the kinds of things like personal responsibility and wellness incentives and premiums and all of those things, those are all available and they have been approved, most notably in Arkansas and in Indiana. Indiana's waiver's gone much further than any other state went. Let's see, I wanted to do King versus Burwell before we wrap up. So another thing that's hanging over every state, not just Texas, is the question of what the Supreme Court's decision will be. And obviously, I said we have 1.2 million people enrolled through the marketplace right now, and about 1 million of those have subsidies. So that's 1 million people with coverage today who, if that system comes falling apart and subsidies are removed, we lose their coverage. And the folks who are studying this in a detailed and academic way are also projecting that a lot of people in the straight individual market that's not subsidized will lose coverage too, because the loss of such a large number of people who are disproportionately healthy out of that 1 million folks from the pool is going to drive up rates so badly for the remaining insurance pool. So there's a great deal of alarm about what would happen if there were no solution. And I don't bring this to you with a particular solution. I think Congress is obviously going to have to be involved in any real solution. It's not an easy thing for a state to pull out quickly on its own. I do want to point out one of the statistics that jumped out at me when I was pulling these together is that over 2/3 of people in Texas have incomes below 4 times the poverty level. That's the upper limit for subsidies in the marketplace. So you can see why this does end up touching a lot of the people who have to get their coverage or outside of employer-sponsored coverage. I want to see one more slide and then probably hand it up. Oh yeah, this is where I get into we can talk about this later, but when we start talking about unsustainability and there being a particular problem with Medicaid, the one thing I would point out is this This is all of the OECD countries, and this is the United States. This is our average spending per person on health care. So we are way up here. It's almost $8,000 a person. And the next country over, which I believe is Norway, is somewhere around 5,300. You know, and these are all countries that have universal coverage. and we're managing to spend that much per person on average, even averaging in 40 million people without health insurance. So we have a healthcare spending challenge that is very real and very true in the United States, but it's not being caused by Medicaid. That's one of the main things I want to point out. This is everybody's healthcare. And I just will show one more, and then I will hush and let Jamie talk. And this is all of healthcare spending in the United States, and this is from Congressional Budget Office. And basically, it's showing Medicare is about 22% of the U.S. healthcare spending. Medicaid's about 16%. So I'm just, let's put this in perspective. The thing we don't like about Medicaid is that we pay for it through the state budget. And we obviously in Texas have a lot of people who aren't insured, and that's the main reason why our enrollment has gone up. So I'm going to cut it off there, and then we'll hand it over to Jamie with her differently colored microphone.
Good morning. I'm JAIME Dudensing again, and as Alexa mentioned, I'm the CEO of the Texas Association of Health Plans. Our association represents most of all the commercial health plans that offer plans on the market to employers in the small market and the large market. We also happen to represent all 19 of the Medicaid managed care companies. So we hear from all different aspects of the insurance market, both from a government aspect and in the commercial market. I'm going to try not to repeat too much of what Ann said, but as we all know, as far as the commercial market goes, the Affordable Care Act has dramatically changed our market. It created the Essential Health Benefits Package, it mandated those benefits, it created guaranteed issue, it created a marketplace where competition could exist. And we have fundamentally seen a completely new and different market since in the last 2 years. First, the good parts. The uninsured rate has gone down. As everyone's mentioned last week, the announcement was that it's gone down 30%, from 25% down to 17% in Texas, just from what we've seen increases from the subsidy market. I think that, and you talked about how much the subsidies have really lowered the cost of health insurance for low-income individuals. Most individuals are paying about $100 per member per month, which is a price point that more low-income families can afford. Some interesting things that I don't think get talked about a lot now in the last 2 years that we have seen is really two things. One is the increase in the individual market. Our association surveyed a number of the plans during the first year of the marketplace, and we saw a 90% increase in the individual market. Basically, in Texas, there was no individual market before the Affordable Care Act. It was very small. And what we've seen now is an extreme increase in the number of people who can now purchase on the individual market. And as a result, you're also seeing competition happen in the exchange in this market. A good example of this is just within the different metal plans. So in the exchange, you can purchase plans, different costs based on the metal colors, the platinum, gold, bronze, and silver. And what we've seen is consumers are shopping competitively within each of those metal areas. They're purchasing the more affordable package. They're price shopping. And in the second year of the marketplace, we saw the national numbers were that out of the active re-enrollees, so about half of the people re-enrolling in the marketplace actively did this. They shopped, and about 29% of them actually changed plans federally. In Texas, about 50% of those individuals changed plans. This is a large number. This is a high dramatic level in consumerism and competition. Usually in Medicare Part D, you see about a 13% increase, a 13% number of individuals who actively choose and change plans. And if you look at the federal health insurance package for federal employees, you usually see about a 7% change. So what you're seeing in the marketplace are individuals going out and comparing plans, actively looking for the lowest price plan, the best plan for their family, and competitively shopping for it, which is something we really haven't seen in the health insurance market. Now, for some of the I'm not going to say it's completely bad things that we're seeing, but some of the parts and the issues that we're still seeing with the market is that affordability is still an issue. The Affordable Care Act really addressed coverage. It provided subsidy coverage for individuals with low income. It created an option for Medicaid expansion. But it only really messed around along the edges for affordability, and we still are seeing this as a problem. Healthcare costs are still increasing. There's still substantial issues with premium increases. In Texas, it ended up not being as large of an increase as was expected, but you're still seeing large premium increases throughout the country, meaning that healthcare costs are still growing and are still unsustainable. The other thing we're seeing is that access is still an issue. Just today, another report came out talking about the substantial increase in ER visits. So while coverage has expanded and people have more coverage, there still is an access issue. And a lot of this is around having access to primary care, but just because you provide this coverage does not mean that individuals are going to get the care that they need or necessarily appropriately choose the more appropriate care for them. We are seeing substantial increases from ER patients. And then next, we are, one of the issues that we have on a regulatory side that I don't know that people talk about very much in the insurance market is that Texas is one of 4 or 5 states that chose not to enforce the Affordable Care Act from a regulatory standpoint. So we are one of the few states that must submit, insurance companies must submit all of their regulatory information twice, once to the state and once go through a very cumbersome process through the federal level to get rates approved and insurance packages approved. There's also still a number of discrepancies between Texas's insurance regulations and the Affordable Care Act, which creates a number of complexities in the market. And last, we still have a substantial amount of uncertainty around King versus Burwell. The companies are very concerned that if the subsidy market went out, you would see what everyone is reporting, is that you would have a large number of individuals dropping off of the insurance market. And you would see most of these individuals be healthy individuals, which would drive up the cost of health insurance, cause a compounding problem of more people to drop their coverage, and substantially increasing the number of uninsured. So to kind of close, for the most part, we kind of see ourselves at a crossroads. We're looking at the future. There's still a number of problems. One, we still have a substantial number of uninsured, low-income adults that need to be addressed. As Ann mentioned, the discrepancies between suddenly having, what's the different income level, probably about $20,000 to $40,000 for a family of 4 means that you don't have an option to purchase health insurance that's affordable. You're purchasing it for $400 to $500 a month versus someone who's spending $70 to $100 per month to get health insurance for their family. Next, as in addition to the uninsured problem and really needing a solution and a Texas solution, we really still see a collision course happening in Medicaid on hospital financing and the waiver all coming together with the fact that it is the one thing that is keeping what we would call a safety net in Texas still together. And so as we keep looking at this problem of not having a solution for the uninsured and seeing this collision course of the waiver and hospital financing, we really see future problems heading down for Medicaid. And then last, as I mentioned, the ACA addressed coverage, but it really did not mess around too much with reforms for affordability and transparency. And we are still seeing a number of concerns around provider consolidation and the need for consumers to have more transparent information so that affordability can truly be addressed in the future.
Great. Well, I'm going to open up our discussion up here with Medicaid expansion because, we never talk about that. The Medicaid enrollment in the state is growing, even if the state doesn't take the federal dollars to cover poor and uninsured adults. And so, we hear a lot about we need to reform the system before we expand it. What are some of those reforms, Anne?
Well, I think a lot of us in the room would observe that, and the feds have reminded us, we actually have about as high a saturation of managed care as any state. So we've got the vast majority of our enrollees in risk-based HMOs now, and we have moved nursing home payments under under HMO payments. We have moved individuals with intellectual disabilities who used to be out in a more traditional model into HMOs, and we're on track to move medically fragile children into that system. So, you know, sort of a next step for us in terms of the waiver, and one of the things that the feds have said they are looking to states for in renewal of these waivers is all of these smart things you're figuring out with these disparate projects, all of these improvements, whether it's the use of promotoris or better access to mental health services, we want to see you roll all of those into your managed care model. So, I mean, I think that there's a huge amount of room for reform and cost containment, but the bottom line is Texas Medicaid's cost per enrollee, when you adjust for inflation, is lower than it was in 2000. So our legislature has ratcheted and ratcheted and ratcheted down. And I'm sure the health plans can attest to that as well. That includes the premiums that they receive. It's also the case that Medicaid's per capita growth rate over the last decade in Texas and nationally has been lower than Medicare's and much lower than private insurance. So, you know, basically our growth is because of enrollment growth. It's not growing wildly out of control. I mean, there's a narrative there that is not necessarily substantiated by a lot more than the fact that we have a lot of low-income people and a lot of uninsured people. And again, I remind people that, you know, the main difference in our Medicaid program between now and 15 years ago is that we're covering children. We weren't, you know, there were less than 1 million children on Texas Medicaid in 1999. Today, there are 3 million plus 300,000 on CHIP.
We know the hospitals want to find a way to expand Medicaid. We know a big chunk of the doctor community also wants to find a way to expand this program. Where do the health plans land on this issue?
We have always been extremely supportive of finding solutions for the uninsured. And so we support a Texas option that would give Texas flexibility both on addressing the current program and on solutions that would present for the uninsured. To kind of go back a little bit what Ann was saying, you know, when you look at the Medicaid numbers, cost for Medicaid has been substantially growing less and less in Texas. Since managed care took over, we had a study that just came out that showed we've saved $3.8 billion all funds since 2010 compared to what you would have had for fee-for-service. Our rates have stayed flat. It really has been about an increase in the number of individuals coming in to Medicaid that you've seen. At the same time, you know, you have to understand that, you know, some of the realities that they're dealing with at HHSC and at the Capitol is that Medicaid does need to be reformed. I mean, it was built around a program created in the 1960s. There are so many bureaucratic steps that go on with approving and going through a process, and there's very little flexibility when you talk about just creating a community care program that creates more affordable solutions compared to some, you know, having to be force someone into an institution. You go through a number of steps that are very difficult in the approval process just to make the program better and more efficient. It does need to be reformed. If you created Medicaid today, you would never make it look like it looks right now. I mean, if you look back at the last 15 years, CHIP doesn't look like that. Medicare Part D doesn't look like, even the new subsidy program doesn't look like that. It looks more like insurance. And even though we've reformed and gotten close to there, they do need more flexibility to make reforms to the existing program, and they need more options to create a Texas solution.
I want to talk about the federal subsidies, and we talk about King versus Burwell. Obviously, this lawsuit is before the Supreme Court, and it'll, in the end, be up to them whether these subsidies will continue in the form in which they are now. But, you know, and are the stakes higher for Texas just because of the sheer number of people that rely on these federal subsidies here?
Well, that's a question I haven't really considered. I mean, they're very high for Texas. I mean, you know, if we have 1 million people who will lose subsidies, they're very high. Obviously, you know, states like Florida, other states that rely on the federal marketplace are also looking at some really, really high numbers. But, you know, the combination of we've already got over 1 million folks that we've left out of the system entirely, and then we are looking at the possibility of yanking back the support that we provided for a slightly more fortunate 1 million people who have gotten subsidies. It's, you know, it would be a tremendous roll back and I think really kind of rock the healthcare world.
Well, and there have been some concerns that these people would be, essentially just dropped off from their health plans. What is that impact like for health insurance companies if you've got 1 million people all of a sudden no longer being able to afford their premiums?
I mean, what you see is a price point issue. I mean, if you start having health insurance creep up to $300, $400, individuals in those incomes that are eligible for the subsidy just can't afford it. So they won't purchase it. The problem is without individuals purchasing it, the additional mandates that were added onto the system, the guaranteed issue piece is probably what causes the economics of it, is that individuals who are sick, the price point's not too expensive because they're going to be spending a larger amount of money if they didn't have the health insurance. So they will keep purchasing it, whereas individuals who aren't sick right now will make a choice to drop off of it. This will skew up health insurance costs, and it creates that compounding problem of increasing the cost of insurance and having more and more people continuing to drop off as the cost continues to grow and escalate. So you would have a substantial hit to the market.
We did have a group of senators and Republican senators in Washington propose a fix the week before last, and notably in it, they proposed that they would get rid of guaranteed issue and also get rid of the protection against pre-existing condition exclusions. And the media immediately noted that that was sort of a non-starter, and the assumption is if a solution goes forward in Congress that they will have to hold on to some of those bedrock kind of principles of the Affordable Care Act, but those are very, very big questions.
Are we holding our breath at all that lawmakers will create a state marketplace?
I am not. No, I think given what we heard this morning, that's not being considered. And I think, it's, as a practical matter, not an easy thing even for a state that's really motivated to do that. Even if there's an option that a couple of states are using now where they basically use healthcare.gov, but it's considered a partnership. But even to do that, the state would have functions it would have to take on, it would have appropriations it would have to make, and I don't, unfortunately, have not heard any of our leaders discussing that as a contingency.
I mean, it took years for some of these states to create their exchanges, and many of them failed and ended up using the federal exchange. So it is very complicated, and if you look at reports, you'll even see that the federal exchange is actually performing better than the state exchanges on individuals signing up and how well it's performing and working. So for the state to take that on in such a short time period, I mean, the realistic side of that is probably impossible. So some other federal solution's going to have to be presented.
Let's talk a little bit about the 1115 waiver, which in layman's term is federal funds that help state hospitals cover uninsured patients. The federal government has said that Texas' reluctance to expand Medicaid will play into this renewal or the amount that will be renewed. Is this a wake-up call for lawmakers? Do you anticipate that this will result in any sort of reform or expansion?
Is that a question for Jane? Well, no. I hope that it is getting the attention of lawmakers that this is an issue. I think there's so much pressure to hold on to talking points of just, opposition to finding a solution, to our coverage gap that hopefully the accumulating evidence of the cost benefits to the states that are doing a coverage gap solution, the accumulating evidence of states like Indiana and Arkansas who have, built these very, very conservative practices into their 1115 waivers for coverage, will start to encourage them. The fact that we've got all these chambers, the fact that we've got the county judges of every urban county in Texas endorsing. I mean, hopefully this evidence does start to build up and people start to consider it, and hopefully the plight of our hospitals. So the waiver is kind of complicated. You got one chunk of money that is, in fact, payment for uncompensated care, and you have another chunk that's for these reform practices, and it's really the uncompensated care portion that most is in question because of this issue that's been raised by the feds. But the bottom line is our big urban hospitals in particular that have matching dollars to put up for the waiver have been buffered from the Medicare reductions that have come through the Affordable Care Act that were intended to be offset by Medicaid expansion. They've been buffered from the impact of that by having this waiver. A lot of smaller and more rural hospitals don't really have as much buffer because if they have any matching funds to put up to participate, they're very, very small. So they're feeling more pain, and that's why we're hearing more about hospital closures in rural Texas than we are. If we were to lose a substantial chunk of this waiver, then the impact on our hospitals, all our hospitals, would be considerably more intense, and what it's going to take for that to get the attention of elected officials is not clear to me. I hope it's clear to somebody how we get there. It is important. I mean, everybody needs to have large and small hospitals out there because you never know when you're going to have a wreck or whatever out in rural Texas, even if you don't live there. And the small hospitals are typically the second largest employer after the public school in small communities. So it's really of concern that we've got this loss of hospitals that's going on.
Jamie, what's the possible impact on the health insurance side of things if we do not see this waiver renewed?
Well, there are options for, and this is, I think this was highlighted in the letter. I don't know that it's necessarily just we're going to take money away if you don't expand Medicaid. There's also another issue going on with the hospital financing. And it's important to understand a lot of the waiver was really two supplemental programs that were created. One was because Medicaid underfunds hospitals by about 50%. So they're not really being paid completely and appropriately for the care that they're providing to Medicaid consumers through the rates that were set. And so it was the idea it would take care of that. The other, and part of the other supplemental funding was that they are responsible for basically taking care of the uninsured because we haven't expanded Medicaid because we're not offering any uninsured issues. And so they have huge amounts of uncompensated care. And so without these two pieces, they take a huge financial hit. One of the things that's highlighted in the letter and is a potential other solution is that you can build you can build the funding through the managed care premiums. So you could take you can look at expansion. You can look at a number of options to actually, instead of subsidizing low payments and subsidizing the uninsured through a kind of a patchwork safety net, you can just fund it through rates and appropriately pay correctly in the first place to fix the problem.
Before we run out of time, I want to talk about accessibility issues. I know, Jamie, you've mentioned them in your presentation, but we hear about these rising ER visits. People still not going through the primary care route and using the ER route when they need some sort of care. How much of this is just sort of based on the culture of the uninsured? Someone who's newly insured, has never had health insurance in their life, might not really be keen to knowing that they can go through a primary care doctor instead of an ER visit. Where does that responsibility fall, that education responsibility? Should it be the state? Should it be the health plans? Where do you go? Where do you start?
I think that's an interesting question, and I don't know what the statistics are that Jamie was referring to, but I know Arkansas actually reported that they've only had a 2 to 3% increase in ER rates, and they were very, very pleased with that. And they said they were really worried and expecting a much higher one because of pent-up demand. So I'm not sure that the premise is entirely solid there, that you will see that. I think, like I said, I think we can look to some of the states that have actually done Medicaid expansion along with their marketplace and see some promising trends there. But
Well, and you do usually always, in the first years of any kind of new coverage, even the first years of moving Medicaid consumers from fee-for-service to managed care, they suddenly have new access to care. We usually always see their costs go up because they have built up care that they have not received. And so you will see that increase. On ER care, you do see this, and there is a healthcare literacy issue, an education issue. There's a primary care access issue. There's an issue around having access to more affordable options that are after hours for consumers. Our healthcare payment system hasn't really paid for those type of system reforms. And you're seeing that transition happen, but it's a slow thing to happen. What I would also say is in the commercial market with individuals who've had health insurance for a long time, they also inappropriately use the ER too. So you do see it, and there are things like co-payments that you could use in Medicaid that don't exist right now that helps encourage individuals to more appropriately seek care in the right place.
One of the things that we see, and I know I've read about some new examples of this weekend, is that one of the issues that's embedded in both the private marketplace and in Medicaid is, what happens when you don't have an adequate supply of providers, and frequently it's specialists that we have trouble with. And so, if you don't have a doctor who will get you in for urgent care, or if you can't get in to see a neurologist for your child for 6 months, sometimes your primary care doctor will tell you to go to the ER because that's where your child's going to get that neurological workup that they think they urgently need right now, and they're not going to have to wait 6 months to get it. So, we have issues around network adequacy that are not things that are easy to work out overnight, because they interact not just with who a health plan contracts with, well, that's part of it, but also with, are there enough specialists in your area? And in an area where there are high levels of uninsured, you're going to have worse provider shortages because it's much harder to have a viable practice, if a quarter of the population or a third of the population doesn't have a way to pay. So we have worse than average issues with access to providers in Texas, both primary care and specialty.
Before we get to audience questions, I just wanted to ask, you mentioned, and in your presentation, that there are various lawmakers that, to this point, don't really have a grasp yet on sort of the income changes between qualifying for federal subsidies and not, and I won't ask you to name names, even though I kind of want to. What has been the impact on that as you've seen policy being made? Where does the, at what point do you just have to get them all in a room and make sure they all have the same understanding of it?
Well, I'm not sure I actually have an opportunity to get them all in a room and do that, but I think it is a real challenge. I mean, everybody here who has worked around the legislature does understand that most of the members are not looking at health care. So you have a shot with the ones that do spend time thinking about it at getting there, but you can't overestimate the need to get that basic information out there. I think we all, these things that seem like common knowledge to us are not necessarily things that have popped up on the radar screen of a lot of members. So I'm going to turn it over to Jamie. I can tell she's poised.
I think the waiver discussions are going to create more options to have discussions on, are there other interesting ways that you could spend the waiver money to help deal with the uninsured population. There's also an option coming in 2017, some people, the mega waiver option, where at the same time we're having these discussions around the hospital waiver financing, which is fundamentally what's paying for the uninsured, and discussions coming up on the ability to really waive not just what's happening in Medicaid, but also some of the commercial aspects. And a state truly have ownership over a Texas solution or a program that's not just reforming the current Medicaid, solutions for the uninsured, but also even what's happening in the marketplace. There's going to be an opportunity to have a much broader discussion than they've ever been able to have before, which is, I think, what a lot of them are asking for. So with the waiver happening and creating that tipping point, they now will have the option to have that discussion. It's just not going to be available for a couple more years.
I think the real answer to this is somehow, and I think it's perplexing to everybody who works in healthcare, how access to healthcare became kind of a, toxic issue or something that became symbolic of some giant social issue that seems to have nothing to do with actually people getting, to get treatment for illnesses. And so that's why we're scratching our heads. I, welcomed some of the changes that states like Indiana have gotten approved in their Medicaid waivers, because I was like, oh, good. Once another state with a Republican majority demonstrates that we can do all these things that we've been saying we want to do, we'll get there. That will make it okay to talk about this. But somehow we still haven't gotten there. And I think, frankly, both because of the mechanics of how Medicaid works and the mechanics of how politics work, we've really got to have some leadership at the very top. And, having a governor be willing to talk about it really not being okay to leave 1 million people, uninsured U.S. citizen adults, out of the equation, would be a huge step in the right direction. So I'm just, I'm hoping, again, that the accumulation of this evidence of flexibility and opportunity, will loosen that up and change the conversation a little bit. It doesn't seem like there's some magic piece of information that we've withheld from these leaders that's kept them from understanding it. I don't know how to get there.
Well, we're going to open it up for question and answers from the audience. We've got Julie up here with the mic, so if you'll just raise your hand.
There was a sign that said, "We do not take Obamacare." And my neighbor got a policy through the ACA, and he couldn't find anyone to provide him coverage, so he dropped it and is taking the penalty. And I'm wondering what your organization is doing to affect this situation.
For Jamie?
Right now, providers are not really supposed to be discriminating against consumers if they have a contract with a health plan. In fact, we are very concerned about a bill going through the legislature this session that would require all insurance card to basically identify someone on the card, basically almost put like a scarlet letter on the card saying that they are someone that has gotten a subsidy. And we are very concerned that that would actually increase the number of individuals that would be targeted for someone to say, I am not going to see you because you had help from the Affordable Care Act to get your health insurance. So we're going through our part. Consumers have to report it back to their insurance company if this happens with a provider, and they have contracts with these providers on providing access to care. And they're really not supposed to be doing this, but there's no way for us to know unless it happens. And in the meantime, we're trying to make sure that all protections that are already in place for consumers stay in place and don't change this session, so that consumers have equal access to health care regardless of whether they got their plan through the marketplace or it was subsidized through the marketplace or they got it outside the marketplace. It is all still health insurance, and they deserve access to health care.
Next question.
I mean, it's a confusing thing. I think a lot of doctors may have not even really understood that they had the same people in the same plan, both inside and outside the marketplace and with and without subsidies. So, they were identifying something as an Obamacare plan when in fact it was just a plan that had people throughout the marketplace in there.
Right, it's a private insurer, but the plan is purchased through the marketplace.
But the same plan is sold
Right.
outside the marketplace as well, and with and without subsidies. So there aren't very many networks that are exclusively Obamacare networks.
I mean,
But some providers apparently didn't understand that.
A subsidy is just a way it's financed. Who's paying for the health insurance? It's still the same product that someone's purchasing equally in or out of the exchange.
Go ahead.
This is Grace Shemaine with the League of Women Voters of Texas. I keep hearing about the difference between people who live in rural areas and people who live in cities, primary care providers, and access to networks in rural areas versus people in cities. And I'd like to see if we can't get that addressed. My understanding was, when I was at a meeting last week, was that there's very difficult to find somebody who will see Medicaid patients in the rural areas.
Rural access is an issue across the board, whether it's Medicaid or commercial or for individuals that are uninsured. And there are a number of solutions, that I think that Texas could benefit from: increasing graduate medical education, increasing residency options in rural areas. I think there's some other options, including scope of practice issues that allow, nurse practitioners to have more independent practice in rural areas, or even the use of telemedicine or telehealth solutions that have been more restrictive in Texas that if they were opened up, would create more access solutions for individuals in rural areas.
And I don't think that there's a special solution necessarily Medicaid-specific, Grace, other than I think some experts have projected that if Texas were to go ahead and get that coverage solution, and bring more people into coverage, it makes it much easier to sustain a rural practice if the vast majority of the people you're serving actually have a way to pay for care.
We've got another question.
Yes, please. I messed around with some statistics. And one of the things that I came across is that if you shifted people from the current Medicaid system into the health exchanges, you could reduce both federal and state costs and also reduce the Medicaid enrollment. There are like 750,000 disabled and TANF participants in Medicaid, the adults. But it seems to me, why haven't people looked into that, shifting everyone into the exchanges? And therefore, no doctor is going to say we're not going to take the exchange when they become so large.
Is this a viable solution, shifting Medicaid folks into the marketplace?
Well, I think the complications of that are that currently we have a lower, as was discussed earlier, a substantially lower pay scale for providers in Medicaid in Texas compared to what they would be getting in the marketplace. So you have to adjust the costs to reflect that. And we also have a law, the law right now doesn't, Arkansas is the only state that's been allowed to put even these uninsured U.S. citizen adults, able-bodied adults, into the marketplace. And so we haven't experimented with that. Folks, seniors, people with disabilities, pregnant women and children who are in Medicaid have not been put into the marketplace. So, I think there is a cost factor there. Arkansas's waiver actually had a hard time selling itself as being cost effective because of the assumption that you will have to pay more per person in the marketplace. And they offset that by saying that because Arkansas's marketplace was so tiny and they had so little managed care to begin with, that they would actually, make that pool more robust, more healthier in general, and bring down the average cost there. But that was just for bringing able-bodied adults into the marketplace, not seniors and people with disabilities. Probably not the topic for this audience, but we could talk about it later.
I will say that, it is an example of something where the state does not have as much flexibility to consider something like that. As Ann mentioned, it's under the law. And so when you hear legitimate complaints about the lack of flexibility in Medicaid, there are a number of populations that are above the 100% level that could be eligible for the exchange, that get some or all of their services out of Medicaid. There is an issue there on whether or not the feds would ever give you the authority to make that decision.
And I think one of the questions that has to be asked, doesn't get asked or not, and needs to be answered is, what's so different about enrolling people in an HMO in the marketplace and enrolling them in a Medicaid HMO? Does anybody have an answer to that? Our Medicaid program is privatized, and people choose between plans, and it is not real clear to me as an advocate what will be magically different if they're selecting it through healthcare.gov instead of through Maximus sending them a packet.
Right, it would be the benefit structure and the lack of ability to have other commercial components like co-pays or premium sharing, right.
And I think
so
that
there are other aspects of what you see in a private health insurance.
Change.
Right.
We have Stewart-in-law, children don't pay co-payments in Medicaid, except for non-emergency use of the ER, that's the one. And I think if you have preferred drugs and, you get a non-preferred drug, something like that. But basically, there's a lot of protections so that the person at 10% of poverty isn't having to spend, every penny they have on a copayment. So there are some legitimate reasons for having which Jamie and I have been arguing about for years, clearly, that some of the poorest of the poor and the sickest of the sick, need to have some protections from standard cost sharing.
Some copays would not hurt.
You're right. It will make that person with a disability feel much better if they can pay 25 cents for their...
We've only got time for one more question, so I want to make sure we get to it. Go ahead.
Hi, my name is Blair Cushing. I'm currently a fourth-year medical student, and I just had sort of a follow-up question to some of the items that have been asked regarding access to care for people who currently have these private plans on the exchanges. One of the things I've heard from some physicians and within some of our organized medicine communities is that one of the difficulties with providers, physicians being able to accept these plans is that they may have otherwise been credentialed with a health insurer for other particular plans with that health insurer, and then the reimbursement that they were receiving for the exchange plans was actually on par with Medicaid when this provider was someone who didn't otherwise accept Medicaid. So I'm wondering, just based on some of the statements that you all made, that these plans are no different than any other private health plan. Are you saying that now that difficulty with the reimbursement has now been resolved and now all the reimbursement should be equivalent to any other private health plan with the same insurer?
No, I mean, there's a difference in reimbursement in Medicaid, just as there's a difference in reimbursement in Medicare in the commercial market, because of the fee schedule set by the state.
Were you saying that marketplace plans were paying Medicaid rates?
Yes.
I have not.
I've not
I've
heard
not
that
heard that.
particular
So we
point.
had physicians who, that was their entire reason for saying that they did not want to be included on those plans, is because of the reimbursement checks that they were getting, because they initially started off accepting everything and saying, okay, Blue Cross, as an example, if I'm taking Blue Cross, sure, whatever, you have a Blue Cross plan, I'll go ahead and accept that. But then when they were receiving their reimbursement, they were getting a Medicaid rate reimbursement. And that's when they said, whoa, no, I can't accept these exchange plans because the reimbursement I'm receiving is not what I was expecting.
No, I haven't heard that. The main issue I've heard from physicians, and it's a legitimate issue, is this 3-month time period. If a consumer stops paying their premium, they get a sort of this 3 months of they still have the coverage. And in month 1, the health insurance company still pays them no matter what. In month 2 and 3, the physician may not get paid for services. And that's their primary concern, is they want to be able to educate consumers to make sure they keep paying their premiums. That's the only real reimbursement issue I've heard. Now, in other states where they've expanded Medicaid, there may be complaints from providers complaining that the expansion population are getting paid Medicaid rates as compared to commercial rates. But
I think the mechanics between physicians and health plans are complicated, and we see a lot of confusion out there. I don't think there literally could be, there is no literal, you have a marketplace plan and we're paying you Medicaid rates. There may be some confusion about that, and there may be that the communications between health plans and physicians are complicated and problematic, and there are legitimate gripes there. But I think a lot of the stuff that we hear is just flat wrong, and that that just speaks to how confusing it is. And
Part of the misunderstanding around the program itself, the law itself. Well, we are going to wrap it up with that. Thank you so much for being here, and let's give our panelists a round of applause. Thank you so much.